Hello and welcome to the topic Alcoholic Liver Disease in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define alcoholic liver disease, discuss the pathophysiology of alcoholic liver disease, describe the clinical presentation of alcoholic liver disease, outline the investigations in the diagnosis of alcoholic liver disease, and finally, discuss the management of alcoholic liver disease. Let's get started. Alcoholic liver disease is a range of progressive inflammatory liver injury associated with long-term heavy intake of ethanol. Significant alcohol consumption contributes to alcoholic liver disease. There are 3 stages of alcoholic liver disease. The first stage is the asymptomatic stage. This still marks the development of potentially reversible alcoholic fatty liver or steatosis. The second stage happens with continued consumption of alcohol, and this leads to alcoholic hepatitis, where there's evidence of inflammation and necrosis that develop, and this marks the second stage. This phase can be prolonged, leading to chronic liver disease. The third and the final stage is when the patient develops alcoholic cirrhosis, or also known as fibrosis. Now, let us look at the clinical manifestations of alcoholic liver disease. Let's recap the stages of alcoholic liver disease. So we can see this table outlines the spectrum of symptoms and signs you would expect to elucidate in the different stages of the disease. The first stage, which is steatosis, patients may still remain asymptomatic as there's no significant inflammation affecting the liver parenchymal cells. Some patients report feeling pressure-like sensation over their upper abdominal area. However, examination may reveal a swollen liver or hepatomegaly, and this can regress after cessation of alcohol consumption. Jaundice, fatigue, and fever marks the second stage of alcoholic liver disease. Hepatocellular injury, which is a consequence of inflammation and a cause for further liver injury, leads to the inadequate clearance of bilirubin, causing jaundice. At the final stage, which is cirrhosis, portal pressure begins to build up and finally allowing its complications to develop, which are upper gastrointestinal bleeding from esophageal varices, confusion, and lethargy from hepatic encephalopathy. The signs of liver cirrhosis is particularly highlighted here as this is a frequently tested knowledge in the exams. Clinical manifestations of liver cirrhosis generally represent the severity of liver disease. There are non-specific features such as fatigue, malaise, anorexia, and weight loss. Dermal features which are pruritus, jaundice, telangiectasia, caput medusa, palmar erythema, petechia, terry nails and nail clubbing. Abdominal features of liver cirrhosis include hepatomegaly, splenomegaly, and ascites. Not forgetting the hormonal disorders that follow, which include hyperestrogenism, gynecomastia, hypogonadism, and reduced body hair. In women, a massive increase in estrogen can lead to amenorrhea. Other signs which also support this condition are exteresis or hepatic flaps, fetor hepaticus, and Dupuytren's contracture. A history of chronic excessive alcohol consumption that correlates with typical lab and imaging findings is diagnostic of alcoholic liver disease. The lab tests that support this include aspartate aminotransferase or AST being more than ALT, with both being elevated. Gamma glutamyl transferase or GGT is a good indicator of excessive alcohol consumption that has occurred over several weeks. Megaloblastic anemia may result from malnutrition, such as vitamin B12 deficiency and or folate deficiency following alcohol abuse. Imaging studies are rarely required for the diagnosis of alcoholic hepatitis, but they can be used in excluding other causes of liver disease. Ultrasonogram is generally the preferred modality due to its low cost, non-invasiveness, and wide availability. Early detection of fibrosis using hepatic elastography is essential. CT scans and MRIs are more sensitive and accurate than ultrasonogram if liver cancer is suspected. The approach considerations depend on the severity of the stages of the disease. In most patients with mild disease, hospitalization and treatment is not required. However, it is very important to emphasize alcohol abstinence. For patients with milder alcoholic hepatitis, a general diet containing 100 grams a day of protein is appropriate. Provide supplemental multivitamins and minerals including folate and thiamine. Salt restriction may be required in patients with ascites. The 2010 American Association of Study of Liver Diseases AASLD Alcoholic Liver Disease Guideline recommends testing all patients with alcoholic hepatitis for protein energy malnutrition and for vitamin and mineral deficiencies. In those with severe acute alcoholic hepatitis, risk of early death is high. Patients with severe alcoholic hepatitis may benefit over the short term from specific therapies directed toward reducing liver injury, enhancing hepatic regeneration, and suppressing inflammation. Glucocorticoids are used for this purpose. For the long term, the goals include improvement of liver function, prevention of progression to cirrhosis, and reduction of mortality. Only prolonged alcohol abstinence is of demonstrated benefit in all these areas. Patients with acute alcoholic hepatitis are at high risk of developing hepatic failure following general anesthesia and major surgery. Because post-operative mortality rates are high, surgery should be avoided in the setting of acute alcoholic hepatitis unless it is absolutely necessary. Orthotopic liver transplantation is widely used in patients with end-stage liver disease. Most patients with active alcoholic hepatitis are excluded from the transplantation because of ongoing alcohol abuse. In most liver transplant programs, patients must abstain from alcohol for at least 6 months before they can be considered for transplantation, and a thorough psychosocial evaluation must demonstrate that patients have a low likelihood of reverting to alcohol abuse. So in summary, alcoholic liver disease can be referred to as a range of progressive liver injury which is secondary to alcohol abuse. Alcoholic liver disease can be understood from the progression of the disease across 3 stages, which is stage 1, steatosis, or also called fatty liver, stage 2, hepatitis, and the final stage, cirrhosis. Blood investigations and imaging studies can further confirm the diagnosis upon high index of suspicion of the condition derived from patient's history of alcohol abuse. Management also varies for each stages. Usually fatty liver or steatosis does not require any specific treatment apart from cessation of alcohol. Glucocorticoids can be used in hepatitis, which is stage 2, and the final stage, which is cirrhosis, and can be managed by addressing the potential complications that may arise. We have come to the end of this topic. Thank you.